Our distinguished scholars and participants, you are all welcome to our second Sociology Days event closing program. Değerli misafirlerimiz, hepiniz Haldun University 2. Sosyoloji Günleri Sempozyumu'nun kapanış programına hoş geldiniz. We have come to the end of our panels, where many different issues on a variety of topics are discussed. We hope that you have found these topics and discussions informative and thought-provoking. Now, I would like to invite esteemed Professor İrfan Ahmet to the stage to introduce our closing keynote speaker, Professor Ayşe Polat. Şimdi Profesör Doktor İrfan Ahmet hocamızı kapanış konuşmacımız Ayşe Polat'ı takdim etmek üzere sahneye davet ediyoruz.
So as we reach to the final part of this lovely symposium, now we have the second keynote address, and I'm very pleased to introduce Dr. Ayşe Polat, who is an assistant professor in sociology at Istanbul Medeniyet University. She received her PhD in anthropology and sociology of religion from the University of Chicago. Ayşe Polat studied political science and sociology at the Boğaziçi University, and later on she studied sociology of religion at the University of Chicago. The title of her dissertation was Subject to Approval, Sanction and Censor in Ottoman Istanbul from 1889 to 1923. And this dissertation examines the Ottoman governance of Islamic publication and religio-moral public conduct. Afterwards, she expanded her study of historical and sociological investigation of the late Ottoman religious bureaucracy by focusing on Islamic book, print culture, Sufi orders, and public acts. Dr. Polat's current study involves medical sociology, and her recent articles are about the contact tracking teams in Turkey and an ongoing project about comparative study of traditional, alternative, and modern medicine. I'm very pleased to introduce her, and the topic of her keynote is Sociology of Pandemics and Disasters. What can we learn from the experience of filiation? Contact tracing teams in/for times of crisis. Dr. Polat, please.
Thank you, Dr. İrfan Ahmet, for the introduction. Good afternoon, everyone. Thank you again for the nice introduction, Dr. Ahmet, and thank you, everyone, for those who invited me first to the Department of Sociology at Haldun University, as well as those who made it possible for us to be here today. The talk will be based on a TÜBİTAK project which we finished last year, and it was a teamwork, so I should mention the name of other persons involved, myself, and then Zübeyde Demircioğlu, Dr. Hüseyin Küçükali, and we also had a couple of student assistants in the project itself. So what did we learn from the experience of contact tracing teams? It might be just a striking move from talking about disasters and earthquakes and then just going back to the COVID-19 pandemic days and just to remember about the contact tracing teams themselves. So why did we choose to study it to begin with? And there was once time passes by, it's kind of like hard to remember why we do the research at that specific time. But we began the project in 2021 and we ended it in 2022. So we had a couple of aims, but basically one was just to say what can we learn and how can we improve what can we learn from the experience of the contact tracing teams and how can we apply it for the future pandemics or for the future disasters. And I think once you hear the talk, you can see, although like the plague or like a contagious disease outbreak is very different from a natural disaster like an earthquake, the problems might really resonate, and there are so many similarities and differences. And the other issue was like to contribute to the collective social memory. I think it was, we were thinking that it's crucial that for the experience of the people who were in the field to kind of to record, to register what they experienced, what they saw, what they observed, what they thought about the experience itself. And I think we kind of were willing from the very beginning of the project, that was essential for us to kind of have a register, to kind of a record of that, of their experiences. And of course, the other issue is related with the first one, to see how we can apply what we learned from their experiences for different moments or episodes of the crisis. The COVIDization of research, this was a term coined by Payi already in 2020. So basically at the very beginning of the pandemic itself, as you might see there are, and then this is by the almost like not even before the end of 2021, but there are 2021, there are hundreds of like articles published about the COVID-19 itself. Some of them are just about the nature of the disease itself, so more kind of like biological or medicine-wise research. But it's also, there are a lot being done in different parts of the world about different dynamics, from the social, cultural dimension to political, bureaucratic, organization-wide. But however, when we were applying for the TÜBİTAK grant, and that was kind of like, I think, early 2021, if I remember correctly. And then we just did the research to see if there was any work being done about the Filiation teams in Turkey. And that was already like a couple of months after we first witnessed the first case in Turkey, but to our surprise, there was no study available. Even very basic information about what contact tracing team was about was really missing. So that was our real motivation point, to see like first of all, what is a contact tracing team? Who are they composed of? Who serves in this unit? What do they do? Who makes the organization? And how do they run? All those basic questions were just really waiting to be answered. And so today, I would still say there is some work being done about them, but still it's very limited. And broadly speaking, in general too, there is a lot of research being done about the experience of the health workers in different parts of the world during the COVID-19 period. But specifically regarding the contact tracing teams, I think the amount of research is still very limited, both in Turkey and across the world. So that's why we decided to do our research was, as I said, it's already multidisciplinary work, because two of us are based in the Sociology department, but the other researcher is based in public health, who is literally a medical physician himself. And we had two assistants, one from, again, public health, and then one from the Sociology department. So this was really a multidisciplinary research team. As for the method, we just decided, because I shall not go into the details about the methodology itself, but because the knowledge is missing, just to be able to even find out the basic knowledge about that. So to discover the knowledge through the field itself, we thought that a qualitative research would be more beneficial than a quantitative one to begin with. And the second reason was also like, we thought that's an experience, the experience itself, like working and being part of a contact tracing team itself is a phenomenon, so that should be examined through a phenomenological exploration. We conducted basically 21 in-depth semi-structured interviews, when basically we tried to hold the group heterogeneous regarding gender, vocation. I will talk about like different, there are people, like some of them are medical doctors, some of them are just auxiliary or assistant health personnel, like radiology technician, nurses, midwives, and so on. And there are also drivers, which we didn't know before as well, but they were also we learned that they were also part of the Filiation teams. So we also decided to do some interviews with the drivers as well. And also we talked with, if I remember correctly, 3 or 4 directors of the public health, director of the district public health. So basically kind of like people on the ground who went and who worked in the field itself, and also people who made the organization possible. So this is kind of like this is the range of the vocation. As for the gender, it's a mixture both men and males and females. As for the age, again, it's like there are people who just started their career, so who are just recent graduates, so who are in their, let's say, mid-20s or like late 20s. But also there are those who have been actively in medical profession for a long time, so who are about like 40, maybe even 40, 45 or 50 years old. Regarding districts, okay, the title is about the contact tracing team in Turkey, but the project was basically based in Istanbul. But since this was run by the government centrally, so I think most of our findings can be applied to other parts of Turkey as well. But also that deserves to be studied on its own to see like how the experience in Istanbul compares to other parts of Turkey, or even how different regions in Istanbul compare to one another. But still, for Istanbul, we decided to go, we chose 2 districts, and the basic idea was, let's choose one in Anatolian side, one on the European side, just to have some sense of comparison. And Üsküdar and Eyüp, we chose those districts specifically, because of practical reasons. The districts, the public directors of those two districts were welcoming for our research. And especially for the pandemic time, it was crucial that the directors are welcoming, so they can, so their teams can devote time to you when, especially for the high peak time of the virus itself, so they can devote time. So basically, because those 2 districts were welcoming our research agenda, we decided to go with them. Second reason is because as I said, we wanted to choose one district from Europe and one district from the Asian side. That is the other reason. Third, both Eyüp and Üsküdar are comparatively like wide neighborhoods, like large, occupy a large space. So they are not just like two very small and tiny little districts. That's the other point. And fourth, we were thinking that they have a quite mixed population, meaning like socioeconomic wise, gender wise, or political wise, whatever you name it. But they can kind of like they can in a sense represent the heterogeneity or the multiplicity of Istanbul itself. So as I told, we just decided to do a phenomenological research, which means basically we had 2 aims. On the one hand, we wanted to find out what filiation looked like objectively, right? What is the meaning of what filiation procedure is? What did these teams do? How many people served in them? How were they organized? Who organized them? What efforts did it take? And also on. So basically more kind of like the objective side of the story, objective part of the phenomenon itself. But the second side is also the subjective part, meaning like how did the people who were involved in them, what kind of experience they had themselves, like what did they think about it, how did they feel about it, just like the presentations before in the previous session, like okay, it's one thing to be objectively to be in one place, but also subjectively, what do you make out of that experience? Like that's the subjective part. And here the variety, although there are of course differences among the stories being told or among the narratives that we were able to compile, but there are also the similarities and differences that we've tried to find out. And it was the common themes that I will try to explain to you today. And maybe some of you might remember, but it was, I think, early or maybe just beginning of 2021, the Minister of Health, Fahrettin Koca, said in public, pay attention to this word, meaning filiation. From now onwards, you will hear this word much more often. And today, basically, that's this whole talk about the crisis, disasters, and all that issue. Like, if we had this talk like a year ago, like filiation would be sounding in all of our minds. But probably today, for most of us, it's already a bygone word, right? I mean, it's kind of like still fresh in the memory, but it's already almost about to die. So this was the whole idea, even at the beginning of the research itself, to make sure that we kind of keep a record of what was happening, what happened, and how we can restore that for the future. So this is interesting too, like what happened to the really contact tracing teams? And I will end my talk in the same question. Like there are moments when we talk about certain issues, that's a big issue, like everybody and everything is about that issue. But then just like even in the time of like, let's say 10, 12 months, it's just bygone. So that's a lot, that tells a lot about social change, I guess. And so I will just in my talk start with, and also just to make sure that I'm using time efficiently. So I will go over the objective part more quickly, and I will try to devote more time to the subjective part of the story. So filiation or contact tracing, and let me just also say something about the word itself. in the English literature or in the English word, the term used is contact tracing. So there is the case, which is the vaka, right, which is the person who has the virus, who tests positive, and then there are also the contacts, meaning people that person was affiliated either in the last 24 hours or last days, whatever, the measurement changes. But so those are the people called contacts. So contact tracing is the term commonly used in the English world. But for the French, filiation is the term used, and that came, affiliation, the similar terms derived from the same root. So affiliates, filiation, meaning like being in touch with, or that has something to do with the original source. For the Turkish word, the term has always been we don't use the term contact tracing, we basically use filiation, which is the French-derived word, and I think that is the case since the beginning of the early republic, and of course the term was being used before the COVID-19 pandemic in the other like the Ebola outbreak, in the other outbreaks, but basically since the late Ottoman Empire, the medical terms are being mostly borrowed from the European and specifically from the French version. So since the late Ottoman Empire, in the Turkey, commonly the word that's being used is filiation rather than contact tracing, or rather than using the English-derived version. So regarding for the standard procedures, so there is firstly the part about there is a daily workload, right? And there is the organization about planning, like who is gonna go to the field, who is gonna go to which part of the city. And there's a standard procedure which basically the Minister of Health tells what to do. And then there are also tasks that the teams do right after the visit. So I'm not gonna go, maybe I shall just mention specifically, like from once you test positive, you are already listed in the system, right? So you are already listed as positive under the account of the Minister of Health. So that information is transpassed to the directors of each city, and then under city, from the city directorate to the public health directors at every district. So the first person, the coordinator or the organizer at the district level, first looks at the list and see like who tested, how many people have tested positive this day, and then they confirm IDs. Making sure that they have the correct information about the person, the name, the address, the phone number, and all that stuff. And then they prepare a vaka list, they prepare a case list, see how many people who are there, where they live. And then they also take short brochures, like short booklets about basic information. And then they call, this is all happening still before they leave the public health, meaning they leave the office, meaning before they leave the public health offices in the district. And then they call the people, inform the patients, saying like, do you tested positive? Do you have any symptoms? Or like, we are going to be paying you a visit. Check address to make sure they get the correct address. If there's any change about the address, they just note that. And then then the coordinator, meaning the higher person, either the coordinator might be someone within the team itself, or it might be someone named as the coordinator within the district itself, within the public health district, within the Directorate of Public Health. So that person assigns cases to different teams, and teams then are assigned to different parts of the same district. And then they start to go, and they just basically leave the office and start to go for the workload. And the important thing is that they usually start with the cases from the preceding day. So because, especially for the high time periods, for the peaked periods, it is not possible to cover every case that was already in the system on that day. So the next day, they usually start with the leftovers, meaning like with the cases left over from the preceding day, and then that's how they start to go. And this is a very complicated system, but just to give the basic points, the one most crucial thing that in the way that when we see how contact tracing was conducted in Turkey, it is underlined that it has to be done face-to-face, physically in the correct address. So we didn't do digital contact tracing, which some countries did, or we didn't just give a phone call and didn't go saying like, okay, if you don't have any symptoms, we are not paying you any visit. So that's not the case in Turkey, or that wasn't the case for the most of the period. So they literally physically go to the address and do the contact tracing or the filiation face-to-face. So they have a barcode, and then they do test the sample, take the sample sürüntü almak, as we know, they get the sample, identify the contacts, and then if the person lives in a different city, inform the authorities in that city to say like this person has tested positive, so make sure you go to that address, deliver the medicine, give the brochure, inform the cases. If there is a need for hospital transfer, either they call the ambulance or they just tell the patients to to call 112 and 112 to call 112 and then to ask for a hospital transfer. And also before leaving, they get the onam, which is the informed consent of the patients, which literally shows saying like, okay, the Filiation team paid me a visit, they informed me, they gave me my medicine, and I am accepting to stay indoors, meaning if I am accepting to observe the rules about isolation and quarantine. And then also if asked, the medical teams also write a medical report, and this is specifically the task of the doctor himself or herself, not the rest of the team. So, and then, so the team leaves the home, leaves the specific residence, and then deliver samples to the laboratory, and then also keep records, seeing like how many people they were able to reach out, whether some people they cannot find in the address, or whether the person either confirmed to obey by the rules or not to obey by the rules. So this all sounds very technical and very objective, standard procedure, right? And that was the term that the team members kept using. Even at the beginning, some of them were using terms like algorithm. We have a standard procedure, we have an algorithm. We have an algorithm. So what does it mean? Meaning like every step is defined, is approved by the Minister of Health, and from top down, we know what to do, because the guidelines are very strict, there's nothing to do, we just do what we are told to do. But also in the subjective way, so what did the Filiation experience look like? And I think this is one of the most impressive narratives from one person who said, oh, so what is Filiation really? The car, the vehicle, medicine, sample taking, phone call. What else to tell? I think it is really the car. We were constantly in the car. I wonder if I had an odometer, how many kilometers we kept driving around. And this sounds funny, but you will see, especially also regarding the challenges, one of the biggest challenges for the team members was not just psychological issues, but also physically. Like to say, like, I felt like I had headache, I had back pain, I felt like throwing up, because I was constantly in traffic driving in different parts of Istanbul, and also complaints about Istanbul, the bumpy roads, the dead ends, and all that stuff. So that this whole issue about just getting in the car, going to the place, driving, so Filiation comes up meaning just a vehicle. So Filiation teams, who they were composed of. So basically Filiation teams were composed of actually 3 individuals. In every team it was made sure, and this also evolves over time. I think it wasn't necessarily the case at the very beginning, but eventually this is how it looked like. There must be a medical doctor, physician, and there has to be one auxiliary health personnel, and which can be a nurse, a midwife, a technician, sometimes even social service person. And then there is also the driver. And as I told, there is the team that really goes to the field, that really goes and checks if the sample taking or informing, giving the medicine, all that stuff. Those are, we call the saha ekipleri, field teams. But also there is the coordination team, which stays indoor, which stays at the center of the Public Health Directorate, and then like makes the coordination go on from there as well. So I underlined it's mostly manual, meaning like people literally physically go there and they do all this work manually. But also there is a lot of digital and technological tools used, and that should also need to be addressed, because from the very beginning, the Minister of Health developed an app called FITAS, Filiation Takip Sistemi, literally contact tracing system. And that's an application that the team members could use over their phone. And they said it really was a huge asset for them, because at the beginning they were literally writing taking a pen, literally handwriting the name of the person, the address, whether the person was there, and all that information, which, as you can imagine, if you are dealing with hundreds of people on a day, that's a huge work. So then they just developed their own system. Some of them were saying, I was just getting my iPad or my phone, I was just using Excel, and I was just creating this file myself. And then they said, but then very quickly, the Minister of Health was quick to adopt a technological program, or not a program, but just an application, digital application, which was just easier for them to upload all that information. And FITAS has really made a lot of things easier for them. But as you can imagine, in practical terms, and that's the whole issue about the coordination problem. There are many problems that were not envisioned or that were not unexpected, but over time the teams kind of like express their needs or their problems about the application itself. So then the Minister of Health, especially the technology part, they try to improve the program itself. So it's both manual and digital filiation. As for the organization, I think it's already clear that there is a very high, strict hierarchical bureaucracy going on. From the Ministry of Health, it goes to every city, and then from every city to the health directorate, to the health directors at the district level. And then from there, it is also the coordination is not only about the Ministry of Health, but this here you can see a huge bureaucracy working on, because the bureaucracy is really interwoven, meaning like Ministry of Health is in close connection with the Ministry of Internal Affairs, with the Police Directorate, sometimes with the local governance like the Muhtar, Headman, or Kaymakam local governance, and all those things are in cooperation. As for is this strictly just governmental, or is there any part for let's just talk with this previous session again, is there any room for civil society organizations here? Not really. But if there is need for social support, maybe that might be the moment when they are kind of directing the needs for the local man, or for the headman, or for the muhtar, as well as the NGOs, maybe to express, people in a certain district might have more needs than the other ones. So contact tracing deserves Filiation itself is both an output, right? And that is the thing that you achieve, but also there are many inputs, and that's the process itself. So it is both the thing that's achieved at the end, but also it is the process itself, which has many aims, and then the teams are trying to fulfill them. And it requires a couple of resources or it requires several resources probably most of us would not imagine, like the material sources, which I will just name a couple of them in the problems, knowledge, skills, sources of authority, positive team relationships with the patients, personal individual skills, and management skills. And this whole issue about whether the teams were really ready or were really trained to be ready for the field work is a demanding question, and basically the answer is no. So basically they just learned on their own and in the field itself, and some of them just underline how many new skills they were able to acquire through this process, through this experience, whether for others it has been really exhausting and it has been a really kind of like killing experience. Output and targets, this is more the technical part, so I can just leave you with what is already written. So what is intended by the authorities with the filiation to begin with, to identify the source, of course. That has to do with everything to do with an epidemic, with a pandemic, right? If it's a contagious disease, the first idea, the first rule is to make sure that you identify the case and you put the case and the contacts into isolation to make sure, it doesn't contage to other people. So also limit the spread, increase awareness, so let people know more about the sickness itself, inform people, lower the hospital load, through like early diagnosis and early treatment to make sure that less people need to be hospitalized, and prevent chaos in society to make sure they know where to get the medicine, they know whom to call, they know whom to be in touch with, guide people, provide social support, provide necessary medical and social and psychological support. But when we look at the themes that emerge from the experience from the narratives that the team members told to us, I think we can talk about 4 issues that came up. One has to do with the individual health and family problems. The second has to do with the perspective about the filiation, whether they consider it as like in terms of job satisfaction or job dissatisfaction and burnout. The second thing has to do with the challenges, these different kinds of challenges they experience throughout this process. And the fourth has to do with the social observations. This might be kind of like, we might be sort of biased in this because this was specifically one question we asked to them, what kind of social observations you had. Based on our pilot interviews, we could imagine that it's like they are basically knocking every door, right, almost in society. So you can easily imagine they are literally seeing the society, socioeconomic differences, cultural differences, you name it. So basically this was specifically a question we asked, and we got very interesting answers. I will just go over this very quickly regarding the personal health. There is a lot of literature about this, right? Regarding both the people who were enrolled, who took part in the health personnel as health cadres across the world, not just in Turkey. There is a lot of work being done about the increased stress, anxiety, psychological burnout, physical exhaustion. As I said, this interesting thing here is like how, because they need to put on like specific dress, right, uniforms, and then just to put that on, to take that off, catching cold because it's hot inside, cold outside, or like because you are driving for long hours to get the headache or feel like throwing up and all that stuff. But also the specific problem, especially at the very early beginning, the issues about like how to make sure that they are not getting the disease, but also they are not, making sure that they are protecting their families, to make sure that their families are safe. So some of them basically just like sent their kids away, literally. They sent and there was this one nurse who was saying, like, I think she mentioned, if I remember correctly, like she knew another nurse who had 2 children and she had to send them away for 3 months to their grandparents because basically she didn't have time to take care of them, but also because she was really afraid that, they could just get the disease. So for some, but it's not just like, also because the work was very demanding and they had to work over hours, like long hours of work for some periods. So that also meant like they really didn't have much time to devote to their families. So one was complaining, how one husband was just complaining that she even doesn't have time to go and buy a refrigerator when their refrigerator was just broken down. So, but this is also the issues, especially, but some also whether the family provides them some kind of social support. In a sense, yes, especially grandparents were a great asset to take care of children, but also like they didn't tell about what was happening in the field to their families. So regarding psychological support, families doesn't seem to be serving a good deal, because also families were anxious, so usually they were not telling about what they see, what they observe in the field to their families. So it also means family was not really a great sort of support psychologically or like regarding the experience-wise. And of course, the other issue is just also has to do with the professional right-wise problems, as many of us know, like the problems about not to take day off, not to take time off. This is not for the entire period, but at certain time periods, the Minister of Health banned for the health workers to take time off or to resign. And so basically those were really like 2 main challenging issues for them. And also remember, they are just appointed. It is not like people are choosing to be part of the Filiation team or not. So basically it is the Minister of Health or the Public Health Directorate that is just appointing individuals to the teams, to work in the teams. So that whole issue about whether we have a choice or not has a lot to do with the problems faced. At the beginning, again, it was, especially during the time period when there was the curfew and then the restaurants were closed, they kept complaining how sometimes they were just really basically going to bed hungry because there's no place to eat, right? Restaurants are closed. Until you go back home, because all places for eating, restaurants are closed, it was really hard for them to even find a place to eat, and also for kids to find kindergarten places to go. But these issues were more kind of like easily solved at the beginning, both by the central government, but also by the directors at the local level. So they were saying usually it's our müdür, our director that came up with a quick solution. They just order us like börek or something pastry from a closed restaurant before it gets closed. And the other issue, especially for the team members, the major issue, so some get extra benefits from this, like through like being extra paid, but it wasn't the case for the drivers. And that also created a significant sense of inequality among the team members. We didn't hear like it to turn out to be a big issue, but at least some of them mentioned, I think it was one of the actual directors who said, like, I felt bad because, people who were working as doctors in my teams, they were getting good payloads, but as for the drivers, they were just doing the same work, paying the same time in the field, but they were not getting any extra credit for this. So that kind of created a sense of inequality. And also just to keep in mind, some of these people, especially drivers, were just contacted through meaning like that wasn't their full-time job, but they might be just contacted through other workplaces and to serve in the field. So the main issue that I will try to address for the remaining part is basically this whole issue about the job perception. So similar to what has been expressed in many other studies, the issue really turns around the question of whether they felt like they had professional satisfaction or dissatisfaction, and to what extent they really felt like they felt like burnout, tükenmişlik syndrome, as we commonly know in Turkish. And I think one thing to underline, that's important to underline, is to make sure that either we don't create heroes out of the affiliation teams, saying like health workers were really the heroes, or not to undermine their work, and to underline how for themselves as well, like they felt like both satisfied, but also dissatisfied. And it's really the middle ground in between. So it's not really like one way or another, just you are completely satisfied or completely dissatisfied. For extreme cases, it might be one or the other, but for most of the people who served in the affiliation teams, their experience ranged in between, meaning like for certain parts they felt satisfied, for certain other parts they felt dissatisfied. So I'll just read some quotes regarding satisfaction. You are physically exhausted, but you have professional satisfaction as you touch a person's soul. We have been useful to people, we have been useful to society, we contributed to the public health. One way or another, it generates satisfaction. This whole issue about filiation, what is the purpose? Serve people, serve society, serve individuals, and that's for the common good, meaning that's for the good of the public health. That's our contribution. That's one issue that makes them feel safe or that makes them feel satisfied. At a time when everyone kept distant, we in a way offered a spiritual hand to those people during those 10 or 14 days of isolation. That's also the sense that when everybody left, even the close ones left the case or the contact or the person that tested positive, we were the ones that went ahead and that really offered the hand and provided the medicine, if necessary, even the food, get in touch with other people, made sure that they get what they needed. So that kind of providing that need for people for the time period of isolation and quarantine, that seems like really a tremendous positive motivation for the workers as well. And also there is, of course, there is the material benefits and all that, but also there is the sort of immaterial benefits, but that can just turn out to be beneficial in the long term. So a couple of people underlined how they get to know their own co-workers better. So one is saying, I got to know most of my co-workers that work in the same hospital, but I didn't know them well before at all. Because remember, right, hospital is basically in different departments and you are basically serving in your own department. You are probably, let's say, if you are a regular doctor, you are probably not in contact with a radiologist technician. But in this case, people from different departments are mixed and assigned to serve in this filiation team. So that also means that's an opportunity for the people to get to know people that work in the same hospital but different departments, or even people that work in different fields, in different departments you didn't know before as well. Also regarding social network-wise, saying as the other quotes reflects, I met several new people. I have acquired a new network of individuals, doctors, administrators at the Public Health Directorate, technicians, and so on. I think this was either the driver or one of the nurses saying this, saying like, I get to know people normally I would not be able to have access to. Like, it's not easy for a regular health worker, health personnel to get to know the directors of the public health, or it's not easy for a regular personnel to just get to know the higher doctors or higher authorities. But this provides kind of an interesting way for them to socialize or to get to know the others. And this whole sense about the times of exception. So what we do, what we provide. So there are both tangible ends, but also there are more kind of intangible senses of satisfaction. And one of them was saying, it wasn't important for us to arrive home half an hour or maybe sometimes an hour late. I see it as our good deeds for the hereafter. So saying like, okay, maybe I don't know whether I'll get the reward here or not, but I kind of like the person saying like, I have the motivation to feel like I will be rewarded for this even for the hereafter. Professionally speaking, how often can one see a pandemic in one's own lifetime? COVID-19 is similar to a plague outbreak. Everyone cannot witness it in his or her life. It has been a great experience for me. This sounds kind of rather ironic, right? So saying like, we are suffering, a lot of people are dying, you are constantly under stress, whether you will get the disease, whether it will be just minor, just like a regular flu, or whether it will be just deadly. But for this person, I think this was also one of the midwives and she has been in work for about 20 years by now. So she's saying this is an exceptional time. Yeah, I mean, I know it has costs, but also kind of like how often can one see a pandemic? Meaning like health-wise, right, this is not regular. This is a time of exception, but it also means like that's a kind might provide interesting time for opportunities as well. Meaning either regarding the organization or how we understand medicine, anyhow, you name it, but basically this time of exception also creates opportunities. And I think that was already embedded in the previous session we heard about. Of course, we don't ask for earthquakes, we don't ask for disasters, but also times of crisis and times of disasters are also might provide in unexpected ways times for new times for new opportunities. And that's the whole issue about the social change, to what extent we can foresee what's going to happen, to what extent unexpected things can happen. And I think this is basically the moral of the story. Of course, but there is also this whole issue about the in-between feelings, about the satisfaction and dissatisfaction. So just to quote 2 examples, some of my co-workers were crying a lot. They were exhausted. We were sometimes taking up to 600 samples a day, working till midnight. And the other one, it was romantic at the beginning. We were being applauded. Remember, we were all going at night and applauding the health workers. So the reference goes back to that. We were being applauded. It was romantic at the beginning. And then it wasn't easy to hold up to the same level of motivation. But overall, I think we did a good job. Meaning like in Turkey, here in the context, the we is referring to the way that it was run in Turkey. So he was saying like overall, I think we did a good job in Turkey. The sense of dissatisfaction, and here comes also the issues about the social observations. So empty Istanbul streets, right? It's kind of for today, yes, Sunday morning. So I was also surprised to see when it was really empty to arrive here so easily and so quickly. But normally, you know how Istanbul is, how streets are, how traffic is killing each one of us, and we're making sure that we are going to die earlier than the rest of the people. But anyhow, so the pandemic period is also that time period they literally observe the city empty. And this is, on the one hand, kind of is really an irritating sense, right? And I think this was one of the quotes saying like that. There was one woman saying like every day when I go out and I see Ankara asphalt, for those who don't know the Anatolian side, the highway, Çevre Yolu on the Anatolian side, and she was saying like every time I look at it and I see it empty, I kind of like can't believe what happened. So I think that kind of sense of almost as if there is a war that broke out, or like everybody left the country for some reason and streets are just empty, what's going on? So that sense, and to deal with that every day, and remember for them, we might be just indoors because of the bans, but they're just going outside. So they literally saw the Istanbul streets empty. So then this is a different quote. This was one of the doctors, a male, expressing it in this verse. The process had been very draining, exhausting, but on that day when schools were, the process meaning the filiation process, had been very draining, exhausting. But on that day when schools were reopened, I left home and saw little girls in pink backpacks, holding their mom's hands and walking to school. On those curfew days, I was heading to work in tears, facing empty streets. When I saw kids on that day, I said, yes, it was worth all these efforts of the last 1.5 years. So just to be able to see concretely how you made an impact on society, schools are closed now, schools are open, kids are back to society, and how that sense of normalization is beginning from an empty street to kids that are just like fulfilling the street. That's the whole issue, and that clearly creates a sense of satisfaction. But then how about the senses of dissatisfaction? And this is, you will see in most of the quotes, this whole issue about how the professional qualities were not really used or were not really used in the right way. That is one of the main agendas, especially for the medical doctors, of course. And this is a dentist saying, like, I used to complain when I was working in the diş sağlığı merkezi, in the dentist center, and I had a lot of patients, and I was really sick of my job. I really didn't like it that much. But right after working in the filiation team, and I should have mentioned that the filiation team also had dentists appointed as part of the medical personnel. So she was saying, like, after working in the contact tracing team, I really have started to miss my own vocation, my own profession. And then the 2 other doctors or 3 other doctors, especially young ones who just started their career, are saying, like, I have been used like a delivery man. like a getir boyu gibi kullanıldım. Sorry, getir kuryesi gibi kullanıldım. My qualifications were not taken advantage of. So I am a doctor, my qualification is not just to serve the medicine. My qualification, professional skills as a doctor should have been used in a different way. It wasn't part of my job definition to go from one place to another just to deliver medicine. So I'm saying like, okay, the state appoints me, but this wasn't part of my deal, right? I didn't become a doctor just to go door by door and just to give the medicine. At the beginning of my career, just as I started to practice medicine after graduation, I'm not doing my own job. I really feel like professionally atrophying. Köreliyor. Mesleki olarak köreldiğimi hissediyorum. I feel like professionally atrophying. And then somebody else was saying that it's not easy to train a dentist, meaning like, was it really worth risking all this medical personnel? But also let's just make sure that we are not getting too much convinced by the narratives, and we should have our own distance, because remember, they also are going to the field with very high protection. So how many personnel that were in the part of the Filiation team really got the COVID-19 from that experience? I think the number is very likely to be low. But in any case, that whole idea about like what was the role of the doctors in this process, and how the state, in a way, that was good, that was, that real people really felt like they were being served by the state. It was good. It was like psychological support, social support, just to deliver the medicine, make things easier for people. But on the other hand, how could we use the doctors better? Like, and they are saying like it might be better just for the doctors rather than just to deliver the drugs, which everybody basically can do. It should have been better if they could be mobilized just to give more information to the people who are really sick, or especially to talk with people, and especially for those who have more risky sicknesses, like they might have high blood pressure or whatever, to kind of like inform them in a better way, and or maybe just to talk about symptoms in a more detailed way rather than just to go and deliver the medicine. And of course, the other issue is that they constantly compared, and this has to do also with the question that we also specifically asked them, but also in their minds, they also constantly compared the contact tracing efforts with the other efforts, like the ban, the curfew, the ban on going out. And so one was saying like, I will do the filiation, but 5 times more people will get infected from one another outside. And I have this picture about the pool, literally, because that was the metaphor that he was using. So we are trying to get the water out of the pool, but 5 more faucets are just, keep filling it up. So basically, whatever we do, it's in a sense nonsense, or it's futile, because no matter what it just gets filled up very quickly. And the other person was saying, we paid visits to the same neighborhood over and over again, as people did not obey the curfew rules and freely wandered around in the streets in the evenings. So they specifically were expressing their complaints about how when people were sending soldiers to work, so then they were just enjoying in crowds. Or in certain neighborhoods, they were saying, we remember going to the same neighborhoods, to the same address again and again. And every time you go, you see like nobody's really obeying the rules. So challenges, if we are to go over and summarize challenges, I think some have to do with the COVID-19 itself, basically. They know this and they clearly put it this way, saying like how little we knew about the virus itself, and so the limited knowledge of the virus, its treatment, and the waves of the pandemic, sometimes it's up, sometimes it is down, the peaks, and this whole issue about the constant revisions about the regulations, so whether the isolation day is 7 days, is 10 days, 2 weeks, you remember, right? It all kept changing around. This has to do with the nature of the disease itself, but also practically, meaning like it kind of created a higher tension for the team members, because with every time they go, people are saying, oh, but you are saying this time 10 days of isolation, but last week it was 7 days, or I heard from my neighbor that it was 2 weeks. So that's all creating confusion, and also practically meaning like also the sense for them whether it was right to give the drugs they gave, or whether the drugs were wrong to begin with all the way around. So this one challenge has to do with nothing else but the virus itself, but in the practical way, how we address the problems about that. The other issue has to do with, I'll just go from left this time, from the team relationships. They underline that has to be a teamwork, meaning they are doing multiple tasks at the same time, going to the address, making the records, finding the person, if not finding the person, making the phone calls, giving the drug, taking the sample, writing the medical report, and then making sure that you're just heading to the other address at the same time, blah, blah, blah. So this whole issue, they were saying, it's really a teamwork. So sometimes you basically, let's say the doctor goes up and takes the sample. In the other case, because it's hard to climb the stairs, and remember, not every building has an elevator, which they complained about. And so it's physically demanding too. So for the other one, they were just saying, okay, now it's the nurse's turn. But sometimes here also it's unclear because some regulations said that it's only the doctor who can take the sample. For other districts, they said, no, anybody can do that. So you don't need to be, the nurses can easily do that as well. But anyhow, that kind of whole issue about whether you go and whether you list all contacts. So they were saying like, this is really a teamwork. But not everyone, as we all know from our professional lives, not everyone has the same work ethic, right? Some people do their work better than others. And same thing here, of course. Some people did their work better than others, but that also created tensions in the teams. So let's say if somebody goes and makes sure that they are writing down each and every contact, that means the other team members might be just complaining, saying like, this is taking more time than needed. Or sometimes the doctors were just wanted to write the medical report, so that the people can take time off from the work, but others might be just saying, you can just get that done later on, blah, blah, blah. So all this issue about the tensions regarding how the way they did the work within the team itself, but also sometimes competition across different teams. So also there was competition between different districts, right? Which district covers more number of cases, like let's say Fatih, great, they covered, let's say, 100,000 cases on a day. As for Üsküdar, they are very low. Let's say they are around something around 5,000, which creates problems across different district directors as well. So that's kind of like the competition was also a problem. And also this whole issue about the hierarchical relationships between the doctors and the rest of the health personnel. Remember but as you might know, that when we see that normally the procedures or the hierarchy is very strict in hospitals, right? Doctors are the higher, başhekim is the highest, the chief physician is the highest, and nurses and the secondary person just come lower. But here it's more kind of like an equal status, but in practical terms, it's not easy for people to forget their early identities, right? So basically the statuses that were acquired before are kind of applied here, and that also seems to have created some problems, not always, but some problems, some issues. Communication is the major other issue. Language, right? Whether to go and see immigrants and not to be able to understand what they are saying. And it is interesting, like although we did the research only with the 2 districts, it even came up here saying like some team members kept complaining about they didn't know the language of the immigrants, so they really needed like translators. They should have been deployed too. Even for the people, regular people, like sometimes it was hard for them to understand their accent or their language. So communication was a problem. And Istanbul, God, dear, beautiful, but also problem-causing city. So they kept, I just named this as topographic problems, but Istanbul has been an issue in and of itself. So the bumpy roads, engelli virajlı yollar, curvy streets, dead ends, cul-de-sacs, inaccessible buildings, right? You go to the building, either the entrance, it's hard to find the entrance, or there is no elevator up, or it's a real estate, there's a security at the door, and it's really hard for you to be able to make sure that you can bypass the security and go to the address. Intense traffic, and of course, long distance across neighborhoods. So as I underlined at the beginning, they made sure that the rule was that the contact tracing teams really physically went to the point, went to the location, to the residence itself. So they were not able to close the cases even from a distance. And through their GPS, and this is the whole issue about the control and checkpoint, however, their directors knew whether they literally went there or not, right? You can just park the car and then either walk, or you can claim that you went there or not. But through their GPS point, we learned that it is not said, but they know that they were being checked by the central authorities, whether they were really there or not. So Istanbul seems like a problem even before an earthquake hits us, God forbid, but it already is clear that the city has its own major problems in this case too. And organizational problems, I'll just cut this very short, as you can easily imagine, how decisions were sometimes not taken There were problems about the delays, like problems they were expressing about the digital tools, and then they were addressing it to their heads, and the heads were explaining that to the central authorities. But sometimes there might be issues about delays. And also sometimes same thing, just like we heard about the earthquake problem, how sometimes central authorities were really distant and didn't know what was going in the field itself. So they kind of were like coming up with these rules, which are standard, but then in practical terms, the field work itself requires certain flexibilities, which the central authorities were not that easily able to adopt. Patients and then people, so individuals that they really face. Sometimes the issue has to do with their high expectations. In one of the terms of one person, she was like, they were really like waiting to be taken care of like a baby, right? The patients, oh, I am sick, you need to come here. You kind of like, they were literally saying like almost waiting as if they are a baby to be taken care of. Of course, regarding their time constraints, right, that's impossible. And to begin with, why should they be cared like baby? That's a whole other issue. But this is the expectations of the society, right, which can be sometimes unexcessive and unnecessarily demanding and high. So how to fulfill their expectations? There are sometimes unnecessary demands, like if as you came here, why don't you take the sample from the contacts as well? But sometimes they don't have time to do that. So they say like, if you are feeling suspicious, you should just go to the hospital to get the sample taken. But then people are resisting to this. Also this whole issue about rejecting being tested positive or rejecting to be written as a contact, also sometimes is physically or verbally assaulting the health workers. So one person was saying like, we literally, a man, I think I can't remember which neighborhood she was saying, it might be Aksaray, but I might be just I might just misremember it. And he was saying, we went to the place and we told them that you are COVID positive, you tested COVID positive, so we are here and we need to get the information, blah, blah, blah. And the person just got the stick and left the house, and they just started to run away just to make sure that they are not going to get physically assaulted. But of course, there is always the bad stories and the good stories. And in the other case, for some other neighborhoods or some other apartments, residents, they were just very welcome. People just invited them in at a time when they were supposed to be isolated. But anyhow, that's, human mind works in different ways. So, and then they were just offered tea, sometimes even food, or like, just had very positive reactions as well. But also there was sometimes really hard moments, hard times. The field itself had, of course, this whole issue this is all about difficulties in the field itself, like practically when you do the work, what kind of challenges you face. But one of the very basic issues is also the wrong address, wrong phone numbers, and security problems, as I just told before. So and then you will just see in the codes in a minute later, one person kept underlying, I just got to learn from this experience that we are really a code, we are really a society on move, we are a göç society, we are a migration society. So, and then she was joking also like how even herself is registered in Van because she used to live there, but now she's working and living in Istanbul, but officially she still looks like to be in Van. So if she gets positively tested, it is going to be the people in Van who will be looking for her. And then they kept saying, we were really surprised to see how so many people have wrong phone numbers, wrong addresses. And I will just have a long quote, but that also tells both about the migration and movement within the society, but also how state officials are kind of like, state officials, even the medical personnel can be just blind to that. That's an issue to wonder about. And then the basically problems about equipment, sources, and skills. Sometimes they didn't have enough cars, digital problems, or like limited experience and knowledge. And I will just save that for the sake of the time. So social observations, and I think we basically came up with two terms from here, as most of us already know this term. So I already said that about society on move. So we already know about this whole concept about the medicalization of life, right? How when medicine starts to dominate every and all fields of the society itself, which is a problem, but also the COVID-19 period is kind of is an extreme way, has to do with the medicalization of life, but it's also about the medicalization of homes, right? Domestic medicalization. And so on the other hand, it also has to do with the domestication of medicine itself, because this is one of the rare experiences where the health personnel, where the health workers are literally going physically to the residences of the patients and really seeing them in their natural settings, right? So it's not like the patient heading to the hospital, heading to the clinic, or heading to the muayenehane and just saying like, I'm here as a patient, but this time it's the other way around. The physician, the doctor himself or herself is walking literally inside to the domestic domain of the patient himself or herself. And that gives them a chance to see the differences, socioeconomic as well as cultural. So I will just have two quotes. One, we drop the medicine. I'll beginning with the end. We drop the medicine at the door. We don't enter the house. However, even when the door gets opened, from the ambience, you can tell the conditions of that person or that family. Can they really afford buying vitamins, vegetables, fruits? Now, if you ask us, I can tell you which parts of the neighborhood are needy, which are not. So kind of like the doctors or the health personnel turning out to be taking our profession and trying to reach society in a completely new way and say, I can literally label you which neighborhoods are in more poverty, which neighborhoods are the healthy. But just don't get me wrong, this is not to say that the virus was just affected only in the poor, which clearly is not the case, but the dynamics are different. So, I'm not gonna have that quote, but one person was telling like, so how in a very rich neighborhood, and then they just went to pay a visit to the person, and the mother was very welcoming. She welcomed the team members, but the daughter kept resisting that she will get the test or she will obey by the rules. So they literally didn't know what to do, how to handle the situation, and the mom kept insisting that find a way to convince her that she's not going to leave the house, and she was even planning to go abroad. So make sure that you make sure that she cannot fly. And I think they basically were saying, like, in these kind of cases, we basically just call the police directorate and inform them, there's this person who might not obey by the rules of isolation to make sure, they don't get on the board. And you already also heard rumors about how people are kind of not obeying by the rules, but also finding ways to say, like, not to get the punishment for that, like, to change the test results and all that stuff. I didn't hear anything like that from the team members, but this is just rumors that we kept hearing. Anyhow, so this whole issue about different regions, the socioeconomic differences between different neighborhoods, and so they were saying, like, we got to see the very rich, but also got to see the very poor neighborhoods. So basically, the questions that I think we are left with is basically, can medicine meet the social, right? And also, your health is our priority, but, right? So the whole issue about, so I will just have the quotes, and I think these two will be the questions that I will leave you with to think about. So I'm quoting, one person was saying, I think the biggest problem for people was to meet their daily livings. They said, you cannot write me, you cannot register me as COVID-19 contact, because then how will I meet the ends? How will I bring bread home? Seeing them, and she was saying, like, or he was saying, how seeing them in such cases really made them cry. So it's not just physical exhaustion, but also the exposure to the social is how it is affecting the health workers. And then this other quote, we are telling people, separate your room, if possible even your bedroom. I was feeling ashamed to say so. Böyle demekten utanıyordum. How many individuals were living in just one single room? The door is being opened. I see 5 people in the same bed. Some people sleep on the couch, some people sleep on the floor, some on the couch. I wonder, what am I supposed to say? So how, can medicine really meet the social? Your health is our priority, but whatever medical advice I give, can it, transpass the problems about the social problems, socioeconomic problems, and really reach out to you? The last one, not just poverty, but also so many people live alone. And this is the observation. I saw them. Many of our elderly patients are living alone. And I think this is a new observation too. So see how, first, the number of the elderly population is on the rise, but also the number of the elderly people who are also living on their own, which has to do with previous social change, but also how that left people more vulnerable, meaning like they are elderly, but they also live alone. And he was one person, after, I forgot to tell that, but after we finished the interviews, we also did a workshop. And then at the workshop, we had attendance, we had participants from different districts, and then basically we just presented our presentation, and then we wanted to hear the ideas about the people who also were enrolled in the Filiation teams. And this was one of the examples that person gave, saying like, we also were kind of lucky because we got to see also very rich houses, very rich neighborhoods, like we have been in Bebek, but we also have been surprised to see how most of the people living in very wealthy conditions in Bebek are just old people who are living with their göçmen, with their immigrant, foreign caregivers. So narratives of self-conviction through the cases. As I saw this whole dilemma about to what extent contact tracing was effective medically and what problems were embedded in it. And this whole issue, there is one long narrative, and I'm just going to cut it short. But basically, I think this was one of the ways for the team members to see that what they do really generates some fruits, some benefits, some concrete, tangible outcomes out there. And so he is telling like they went to one apartment, one high-rise buildings, and they basically rang the bell, nobody opened. Then they rang another bell, and finally somebody opened the main entrance door. And then they just climbed the stairs, they went up, and they saw that the door is open, meaning not the main entrance door, the building door, but the door for the house itself, for the apartment itself was left open. And so they just scream saying, is there anybody in? And then basically, then they just saw this one guy, and then this is the story. This is the man who is talking. I lost my father 3 days ago. I also lost my mom. One of my older brothers is in the intensive care now. Another one is in the hospital, but because it is overpacked, meaning the hospital is overpacked, he hasn't been able to have any treatment yet. I do not feel well either. Our family is being badly affected from the COVID-19. It's likely that I will die too. It's likely that I will not survive. That's why I left the door open, so that at least when I die, I will not be alone just by myself, but so when people come in like you, they can just get in easily and take my deceased body away. So basically, this is just a person. Just remember the same scene. I think at least for me, it's very similar, right? Like those images from the earthquake, and when people are really literally waiting under the collapsed buildings to be saved. So same idea here, like a person just waiting desperately, saying like, it affects my family badly. This person died, it's very likely that I will die too. So at least, I can die, but at least, I don't, so you can easily find me. So that's why I'm leaving the door open. And I think this was one of the moments when the person was saying like, just seeing that scene has really convinced me that what we do, yes, it has problems. Yes, it could have been run better, but it also has really very concrete benefits. So challenges and dilemmas, and I will just end with marking this. And I think as I was making comparisons throughout speech, these are challenges. Some of them are specific to the COVID-19 itself, but some of them can easily be applied to other cases as well. So what to prioritize? Quantity versus quality. For a pandemic, when it's crucial for the team members to cover up, to visit more cases, of course, quantity matters, right? It's not easy to say, like, I can deal with only 10 cases today when the numbers are in 10,000s. But also the quality, because then this whole issue about filiation is kind of like quantitative versus qualitative research. It's not just to us to get the figures, to get the numbers about how many people were in contact, but to take a deep synopsis, to take a deep diagnostic narrative, and to see whether people have symptoms, what kind of symptoms, who they have been in touch, blah, blah, blah, all that story. And that requires more time. So that's kind of a sacrifice, whether you are going to choose quantity or quality, or how you will achieve the balance in between. That's a major issue. And the quotes are just examples for that. I will just skip the first one. And then the second one was saying, the fastest you do, meaning the fastest you do the contact tracing, the more the quality of the filiation drops down. We cannot keep up with the number of the cases. The more cases we try to cover, the fastest we go, and we sacrifice the quality of the filiation. That's to say, not all contacts are added, and not all medical reports are written. So it has not just like to make sure you get all contacts, but also whether you can fulfill all the tasks you were supposed to fulfill in the field. Short-term versus long-term benefits and costs. Who should be deployed in the task, right? That's the main issue. What is the role of the doctors? What is the role of the medical personnel? What could be the role of the supportive personnel? And what skills also for the benefits, did medical personnel really attain any skills in this process? They say they did. Like one young doctor was saying, like, I am normally not a good social communicator at all. I cannot talk with people. I cannot talk with my patients. But throughout this process, I got to learn to talk to people. And she was even saying, like, literally, she was saying, I learned how to make a phone call. That sounds weird to us, but in the age of WhatsApp and all that stuff, right, maybe for most of people, even for the new generation, even just to give a call might be a skill to be learned. And she was just a recent graduate and saying, like, just to call a person, make a official phone call, have a decent conversation, and that just to even learn that skill. And also skills about resilience, right? How to feel like, okay, you make sacrifices, you try to protect your family, but also how you are trying to help the people. Anyhow, there are many different soft skills they were able to attain and acquire in this process. But then, is it really worth that? Could they learn that in different ways? Or what cost did it cost to those people as well as to our country? In that regard are also issues to take into account. And I think this whole issue about physicians really, like the medical personnel or medicine seeing the society itself, is one of the major issues about this whole issue. Optimization parameters. So was the contact tracing effective? To what extent? Compared to which other measures? Could it be run more effectively? If so, how? I think this is also part of the story that definitely the central government or the central authorities need to inform the public in a much better way. Even for the affiliation teams, it's not clear in their minds to what extent, specifically to what gap did they really feel, what contributions they made. And this could be just provided in figures, right? Like when you do a good contact tracing, how many people does it mean that you are saving? How many people does it mean that you are saving from getting the disease contagious? Or is it just a futile effort really in the face of COVID-19? Was it just like meaningless? Like the way we feel today, right? Does anyone know here whether the contact tracing teams are still enforced? No. Do we know the numbers? Anything about COVID-19 cases? What did happen to the illness? Did it just disappear? Or did it just get worse? Or did it just get better and everything is going to be fine from now on? So all these basic issues, not clear both for the public itself, right, broader public, but also even for the medical personnel. So it's the duty of the central authorities to provide more transparent information, to share the data, and to concretely make people see the benefits of like what they do. So I can just effectively use a narration, right? The man who left the door open. Of course, that's a tragic story, right? And I'm not undermining the story. That's a very valuable story, and that's why I just go over that at every presentation. But also, it's just a story. And then a story can be convincing for just one person, two person, but also numbers can be sometimes, or like the ways to effectively prove to the public to what extent contact tracing really was successful, in what measures we did a good job, in what measures we didn't do a good job, to kind of have a reflection on that, to keep a track and to share that with the public. I think that tells about how to manage a crisis moment. And I think this is a point that can be taken away basically to do anything from pandemics, from pandemics to earthquakes or you name it. So this issue about bureaucratic governance, the dilemma between centralization and decentralization. Centralization has its benefits, right? And sometimes was maybe one of the greatest assets. And because they also empowered the affiliation teams to say, like, this is not the rule I put, that this is what the government tells, or this is what the Minister of Health says. And they have standard procedures, so they know what to do. It's very bureaucratic, very nicely organized. So it gives uniformity, it provides common standards, it provides the power of connection between different departmental units. But it has its assets. But the problem about over-centralization is also that it makes people take less incentive, meaning those in the lower cadres are much more hesitant to take any initiative and to do anything, right? Just we heard about the earthquake studies. Unless there is a call from the center, nobody's doing anything, but there's a problem right in front of us. So is it like, how long am I supposed to wait until a phone call arrives? So people are hungry, basically. If my affiliation team is hungry, do I need to wait until the government says, okay, keep restaurants open until this hour just for the affiliation team? That doesn't make right. Like practice doesn't work in that way, right? We all know that. So this whole issue about the over-centralization, how it sometimes create problems between the higher cadres and lower cadres, between the central authorities and those in the field, and might limit the capacity for people for autonomous decision and action taking, and inflexibility in rules. And we can just skip that. So basically, I will just end with three themes that I think can rapture or can summarize today's talk. One is about the medicalization of life. And the other is about the domestication of medicine. And third, I don't know, this is a term that I'm just working on, and I don't know if I can come up with a better one, but ruptured public mobilization and governance. So discontinuous, non-transparent public informing and crowdsourcing. What happened to the Filiation teams as well as to the COVID-19 cases and vaccination, right? And then what does it leave for the room? It leaves a room open for conspiracy theories, right? So most people there are a significant number of people who are conspiring whether there was a disease to begin with, the benefits and the damage of the vaccination. But once you leave the room open, right, all those things can easily flourish or like mushroom. So this whole issue about ruptured public mobilization and governance, when there are moments of social change, but also the way that the governments or the states are responding to them, to what extent that was very centralized, very organized, but then all of a sudden it's kind of like, boom, right? All of a sudden it's just like a really like a continuous disappearance, and that doesn't make sense. That doesn't make sense for anything. That doesn't make sense for governmental organization either. But this, of course, this is not specific to Turkey, right? Just to underline the point, and we see the same trends going across the board, globally. But I think this has a lot to do for us to think about. So the room is basically for public trust versus conspiracy theories, trusted and conspired presence and futures. And I think especially for the sociology, and there is a very recent issue that came out by the Sociology journal itself, which is the future of sociology itself, but also the future of society itself. And I think in between this tension, how we are envisioning today, and there is an embedded future and past embedded in today, present, right? So it's not like past, present, future. They are just like three separate compartments, but they are really intermingled. And how we are reading what we are reading in present, whether we are going to just leave room for conspiracy theories, or how we can create trusted publics, trusted common social well-being. I think that's the main issue to take away. So thank you for your invitation to begin with, and thank you for the attendance and attention, especially at the end of we ran longer than we expected. So thank you everyone for listening.